My name is Cherry Harriman. I'm a director for residential care in Fraser Health, and I'm very happy to be able to introduce the speakers on, I think, this very interesting topic. Death is death a dirty word in residential care? And we ask that question with tongue-in-cheek. We know that the average age of people who live in residential care is about 86 now, and it is increasing. We know that many residents who live in residential care have multiple chronic illnesses, many of which are terminal. And we know that people are now spending less time in residential care with all of the community initiatives that are starting to be developed so that people are able to live longer in their communities. And what we're seeing now is residents are living in residential care on average about 16 months, and that is also decreasing. It always surprises me that sometimes people, and I'm saying families, residents themselves, and staff, really don't think that death is a part of being in residential care. So we're very lucky to have 4 speakers who will really be bringing us some insight into the impact of not really acknowledging death and how we can work in our residences to make the quality of dying much better. So it gives me pleasure to introduce 4 people. Dr. Romaine Gallagher, who is the head of residential care and the palliative care division for the Department of Community and Family Medicine at Providence Healthcare. She will be speaking first. Second, Della Roberts, who is a CNS in Fraser Health for the End of Life program. Dr. Peter Edmonds, Medical Director for North Shore Palliative Care Team, and Gina Gaspard, who is a CNS in Fraser Health in the Residential Care Program. So thank you. Romaine?
Thank you, Jerry, and thank you very much, everyone. I appreciate being invited. I think death is really a taboo subject in all conferences. I specialize in speaking last, and that's usually because people think that's the appropriate place for us to start. What we're going to do is, between the 4 of us, we're going to give you a picture of what people are dying of in residential care, what the picture looks like, what the barriers are, and some of the solutions that various people and teams have come up with to try and deal with this. Myself, personally, is death a dirty word? I wanted to change that because I don't feel that, and I think we'll discuss that as we go along. So, prevalence and other facts about death in residential care. If you look at the locations of death, this is a pie graph from 2010 looking at where people die. And you can see residential care is in the pink here at 24%. So a lot of people in British Columbia spend their last weeks, months, and days in residential care. It is BC's largest hospice. And I personally think we need to start viewing it as that. We know, I also want to show you here that more and more people have been dying in residential care. If you look at 2002 here, in extended care, as they've got it here, 5,213 deaths, and it's up now to 10,005 deaths. So yes, there has been an increase in the number of beds in residential care, but I think we can say that over this time, residential care has been asked by the ministry to coping with increasing numbers of people who are in their last months of life. Can you pass me my water? Thank you. You think with all this rain I wouldn't be thirsty. So definitely we are an aging society. I think there's no point saying we're going to be. We are. And there is already, we can see, increased number of deaths. Most people nowadays have what we call multiple diseases, multiple comorbidities. And these things are synergistic. They add up together to make you more frail and more vulnerable to the sort of the straw that breaks the camel's back. What this does is it results in it being far more difficult to predict when someone is going to die. Not like it used to be and not like it typically is with cancer. So only 20 of us will die with a recognizable terminal phase. Who lives in residential care? Well, about 32% of people over age 85, and 70% have cognitive impairment. So, a lot of people living in residential care are dealing with dementia with multiple comorbidities. Now this is I don't want you to really pay attention to this slide because it's rather daunting, but it just shows you there's many ways to approach the door to the end of life. You can, or you could say circle the drain if you want to. You can spend a long time circling the drain. You can take a dive straight down it, or you can swirl your way around a little bit and then finally go down, basically. But knowing how to recognize these is important, right? And with dementia, what the important thing here is that many people spend a long time prior to their death with persistent severe disability. And to put it bluntly, if you're always looking like you're circling the drain, it's hard to understand when you're going to die, how to recognize this, and how it might be different from anything that's happened in the last few months. How do you tell? And I have been wrong so many times in trying to talk to families. I've also had families say, oh yeah, this is the 6th time they've told me that Dad is dying. Yes, so what? And Dad will probably be eating breakfast tomorrow morning. And maybe Dad will, but maybe Dad won't. And this is part of the problem. I also want to impress upon you that the more of these chronic conditions you build up, the more complex you are, and the more health resources you use, and in a way to not try and excuse some of the very distressing things I heard family members talk about, but to say that these people are incredibly complex and difficult to manage, and we clearly need to do a heck of a lot more work on that. And I think in some ways, what I found is that people in residential care were some of the most complex people, and many people just didn't realize that, right? And just sort of thought, oh, well, but they're very complex. They have multiple things that can cause things to go wrong and to go right. The prevalence of dementia is absolutely growing. We all know that. And I want to tell you that it's been a long time until people recognize that dementia is actually a terminal illness. And I think the best thing that we can do as a society and as a healthcare system is to recognize dementia as a terminal illness. And some of the reasons why people die, we often sort of say, well, they died of pneumonia or they died of an infection. Yes, we know people with dementia who cannot walk, and anybody who just lay down and didn't get out of bed, but particularly people who are frail, they have a much higher risk of having a urinary tract infection that spreads to be a total infection, and they have a much higher risk of pneumonia and pressure ulcers. We now know that following people with dementia, the mean survival from diagnosis is actually not that long. It sort of depends how long people can manage to function with it before it becomes evident and begins to affect their ability to manage in their current circumstances. And you can see that the median survival, this means half the people lived less than this, half the people lived longer than this, was actually not that long. The study that really hit home the most was a study of 325 residents, and you can see this was only 2009. And they followed people and looked at what happened to them in the last 18 months of life. And they also talked to their decision makers and their family members about their understanding of what was going to happen to their loved one. And they noticed that there were key signposts that sort of said, we're getting closer to death. And one of them was getting pneumonia. One of them was having a fever. And the other one was starting to have problems swallowing and eating and difficulty managing food and so on. And they saw these as key signposts because half the people, almost half the people, were dead within 6 months of the beginning of these incidents. Now, what they found is, though, over the 18 months, a lot of people suffered from symptoms which weren't necessarily controlled as well as they should be. So shortness of breath. This comes primarily from muscle weakness, and that people just, are not getting up or not moving, etc. And I'm going to show you why this can't be fixed by saying, well, why don't we just get them out of bed and make them walk more? Okay? And pain in a lot of people, pressure ulcers, agitation, 53%, and that the symptoms got worse towards the end of life. They found that 41% of residents ended up having some burdensome intervention like visits to emergency, multiple tests and things that weren't going to really improve their outcome. But that when family members understood the natural course and expected outcome of dementia, in other words, they understood that their relative was dying, they were more likely to have, less likely to have really difficult interventions like back and forth to the hospital and so on. Unfortunately, surrogates or decision family members didn't receive enough counseling about the prognosis. Only 18% felt that they'd been told what was actually going to happen, and only a third about how things were going to progress. I like to show this to family members because people say, well, my dad only has problems with his memory, and say, unfortunately, no, your dad or your mom has problems with their whole brain, and that's why they have problems eating, they have problems walking, they have problems managing their bladder and bowel. It's because the whole brain is affected by dementia, unfortunately. And of course, complex systems break down first. So memory, the ability to speak and so on, are affected soon in these things. And of course, basic, and swallowing actually, because it's quite complex. And the basic things like being able to get up and move around may come somewhat later. We did a study looking at bereaved relatives of patients and residents who died in our organization. This was in 2011. We did a total of 90 interviews because it was a 45-minute telephone interview, and so, you can only do so many of those. We only had 13 interviews from residential care. But what we found is that, first of all, 5 of the 13 died within 2 months of admission, which meets the criteria for hospice, by the way. and 11 of 13 died within 6 months. So our experience of the 18-month average length of stay, from my perspective of doing palliative care, is we don't see these people who live so long. It seems like a lot of people come in and actually meet the criteria for hospice. The reason why I point this out is because if you look at the overall care received in the last 2 days of life, and this was the limitations of the study, we're just looking at the last 2 days, the difference in the highly satisfied, excellent care, in other words, 8 to 10 out of 10, it was 89% in hospice and 38% in residential care. So we found quite a dramatic difference between hospice and residential care. And so I'm going to now turn it over to my colleague, Della Roberts.
So I'm going to shift our discussion and say, okay, given the realities that Romaine has talked about, what is the approach we should be taking, or how can we acknowledge this? And I'm talking about a palliative approach. So I just want to start by a little story. And of course, all of us who are here, those of us that are providers who are here, are also daughters and mothers and family members, and we all have our own stories, right? And so I'm going to tell you the story about my grandmother, because good deaths, or deaths that are aligned with a person's values and beliefs, don't happen by accident in our healthcare system. My grandmother said, you know, Della, when you're younger, you may die. When you're older, you must die. And it's getting quite hard to die nowadays. She had been a LPN involved with care for seniors over her lifetime. So death is a natural end to life. It's not a medical event, but when you are in care, it becomes very medicalized. So Emily actually died at 98, very comfortable with her granddaughter at her side. But she was living in a facility in Alberta and had multiple comorbidities and developed cardiac arrhythmia. And although she had very clear expressed wishes that were well documented, supported by her family, still we were asked, would we like her transferred to the city for a pacemaker? I was like, no, she wants to die. She was very animated person, and she said, you know, when my exit off the highway comes, Della, don't let anybody be standing in the way. All of her children had died. She was 98. Two husbands had died. All of her siblings had died. She was ready. So no, she didn't want a pacemaker. Thank you very much. This was her dying time. So how is it that we can respect that death is a natural end to life, and that people that are coming into residential care have multiple comorbidities and are at their final phase of their life? If we look at the traditional definition, this is the World Health Organization definition of palliative care is an approach. So it is an approach, it's a philosophy, it's a lens towards improving the quality of life of people that are faced with life-threatening illnesses, life-limiting conditions, congestive heart failure, COPD, dementia, the kidney, end-stage kidney disease, the multiple comorbidities that arise, and why an older person will be coming into care, because if they didn't have those, they would be out golfing or something, right? I mean, it is because of life-limiting conditions that people are living in residential care. So it involves the dimensions of palliative care, impeccable assessment, identifying early that people have an illness that they will die from, impeccable treatment of pain and other problems, whole person care. So when we're talking about a palliative approach, we're not talking about identifying a point in time to begin all of these things. We're saying these principles need to be applied integrated into care of people that have life-limiting conditions. And certainly when someone is entering and moving into residential care, they're at the point in their advancement of their illness, 95% of the people that will be moving in, that they're at the point in their advanced illness that the principles of palliative care all apply. So it's not linking the provision of palliative measures with like identifying the magic point in time that we should do these things. So it's really a lens embedded into care of all the providers from the time people move into residential care. So it is a core business. It's a core part of residential care. And I was talking to somebody recently, and she was saying, you know, Della, I think we've in wanting to focus on rehab and people living well and fully and engaged in the social model that's so strong in residential care, we have moved away from acknowledging that this is about people's dying time as well. So we're talking about an open, acknowledged approach. And to fundamental conversations, as Romaine's talking about, there needs to be guidance and sharing and shared dialogue so that what means comfort and quality to each of us, which would be different for each of us, can be supported. So information sharing and that whole person care. But if there is not an open acknowledgement that change will happen and death is going to result, and if you're waiting for a magic time to start that conversation, given that we don't know when change is someone's so frail that this innocuous little bit of a flu or whatever is going to stimulate their dying time, we're not going to catch the right time to begin these discussions. And this is kind of the illusion that we're working with, and this is why we're talking about death as a taboo subject. So there's numbers of initiatives going on. I mean, Australia with their guidelines for a palliative approach in residential aged care, they've got self-directed learning packages. They talk about a palliative approach in their moving in process. It's very embedded. There's a document now in Canada called the Way Forward Framework, and the roadmap to integrate a palliative approach to care in all sectors. So the specialization of palliative care has created this sense that there has to be some magic people to do it, or a magic place, or a magic time, rather than and so this movement to have integration of the principles of palliative care embedded. And I'm involved with a group of nursing researchers and clinicians. We have a team grant through the Michael Smith Foundation, and really our focus is to look at how we can support nursing practice, study how we can embed a palliative approach. And the three areas that we're looking at are actually acute medical units, which is where we've had stories today, a lot of people with chronic life-limiting conditions will bounce in and out of, home health and residential care. And so there's my little circle, Gina, thank you. So one of the baselines that we did was a provincial survey of RNs, LPNs, and healthcare workers. We looked at 160 sites across the province. A third of those were residential care settings. And I'm just going to share a little bit of findings that are kind of appropriate for our conversation this morning. So we're asking about people's confidence in applying the dimensions of a palliative approach, their knowledge. But what I'm going to highlight today is we actually asked them, we gave them a definition of life-limiting condition. So the frame of dementia, COPD, congestive heart failure, kidney disease, and said, okay, if you think about the people that you're looking after, how many people, if you thought of the people you're looking after, how many out of 10 would you say had life-limiting condition? And this is a really, as Rick describes it, nasty slide. But the blue here is residential. Green is hospital and red is home. So I want you to pay attention to the blue. On the bottom is 0 out of 10 patients that have a life-limiting condition. On the other axis is the number of respondents. So I would have imagined in residential care, if you asked how many people that you're looking after have life-limiting conditions, most people would say almost everybody. But actually, more than half the people, there was about half the people, if you think where the median is, about half of the nurses in residential care settings identify 8 out of 10 people as having a life-limiting condition. So the other half some people saw 2 or 3 people. So whereas, so speaking specifically about, well, why might that be? We did also some qualitative studies, interviews, but probably one of the things we think this is about is families and even providers are not recognizing the person's on a dying trajectory. So they see them as a person with functional decline, but not necessarily on a dying trajectory. Romaine talked about dementia is a progressive illness for which there is no cure, but studies have shown that it's not viewed as a terminal illness. And of course, knowing that you need to talk to somebody about disease progression and awareness of decline and death starts with identifying that somebody is going to die from something, right? Besides being old. So, Romaine and her group at Providence Healthcare did a survey of asking, is dementia terminal illness, to different providers. And I think the interesting column here is the disagree column of how many people disagreed with the statement that dementia is a terminal illness. So it's not well known, and we don't talk about it clearly, that decline is expected, and not in a harsh way, but in an acknowledgement way, especially when someone has reached the point they're moving into residential care. Sometimes we're not talking about that because the decline is slow, as Romaine talked about, that it appears they're dying from something else other than their brain failing from their dementia, and that it's difficult to predict. So again, if we're waiting for the time where we see death on the horizon to begin this work, we're actually not going to begin it, and often till it's too late. And if you look at, it's not even in our death certificates. I don't think, Gina, that you can even put dementia as a cause of death. You can now, but it's very seldom ever identified as the cause of death. And family members believe that their family member has died of other things. So once you identify that someone has a condition that they're going to die from, then so we ask these same nurses, LPNs, and carries, how often would you apply a palliative approach? So have conversations, do assessments about comfort, establish goals of care, talk about things that would be aligned with the person's values and beliefs. And so about 1/3 of nurses felt that they were using a palliative approach all the time. And similarly at home. In hospital is a lot more complex environment. So when we looked at the other aspect, the one big mediator of whether people will integrate a palliative approach is whether they think the person will benefit. So we have to be more clear about articulating and being clear, like describing what will be the benefit for somebody and or their family. Like if each of us knew that somebody in our family, we wouldn't be surprised that they would die in the next year. Our family would probably have some work they wanted to do, some things that were important to them. So if we don't provide guidance, there's things that families and people are not doing. Residential care has equated, the term palliative has been associated with actively dying. So the term palliative in residential care has just become associated with people in last days. So the notion that can be a barrier to then actually applying those concepts. So that's I think one of the things. And the last thing I'll just talk about is waiting for permission. We're finding this interesting finding from the research that we're doing in iPanel that nurses are waiting for permission in their care setting to talk about conversations about death and dying. So has the physician talked about this? Care aides are waiting for permission to say, they don't know that they could have permission to say, oh, your mom has changed. She isn't eating as well as when you were visiting here at Christmas. So we have a lot of barriers around the notion of signals and permissions that I think we could do a lot of work with. And that's going to segue into Peter talking more about that.
So we put these slides together remotely, so there's a bit of overlap. I'll try not to steal all your thunder here. So I was asked to talk about actual practical barriers to why people don't talk about this and make these kinds of plans. And I'll just show you this. So if we back up a little bit and we think about the idea of palliative care and the term palliative care, this is a relatively new idea in medicine, although people have been dying for centuries quite successfully. But it's only 40 years ago that palliative medicine, palliative care sort of came into being as an entity, and it was designed initially to help people who were really suffering in the last days, hours of their life with a heavy burden of symptoms. And so it's not surprising that palliative came to mean death, and that is alive and well today, as you all know. You say the word palliative to a family, palliative care, let's talk about palliative care, everybody throws up their arms and says things like, oh, you're giving up on me, etc., etc. On the other hand, we know that that at the same time, parallel to this in medicine, there's this tremendous push and tremendous development in saving lives, this total focus on saving lives, this massive increase in technology, things we can do. So at the same time, we're educating our public and our citizens and our physicians and nurses to do everything to try to prolong people's lives. And we've built this concept into people's understanding of it. So it's not really surprising if we're not going to talk to them about what's really going to happen, and we're not going to be truthful with them, that they're going to choose life-prolonging, possibly life-prolonging, maybe even non-beneficial treatments. And that's why they would rather go to the hospital, where things might get done that might change things. And so at the same time, we know very clearly that in our residential care facilities, or certainly where I live, there's a 14-month average length of stay. We have these two fairly discrete populations, the younger group that are in there with ABI or multiple sclerosis type things. They live longer, but there's this one, the other group is fairly sick, very sick often, and getting into res care very late. When I started practicing 20-some years ago, residential care was like old age home. That's what we used to call it, right? It was the acuity of people in residential care was far less. And I think that the problem is that we've left with that idea and we haven't really moved on to understand that things have changed. And actually residential care is very much like a hospice in many facilities. And in many facilities, patients are very acutely sick with multiple diseases. So I'm going to talk about what the practical barriers are. I'm not going to talk about what we should do or what I think we should do to overcome these, because Della will have nothing to say after that. And I just broke it up into these sort of groups. This is a major problem. I don't mean to beat up on physicians, but I think our physicians are stuck a little bit in that old idea that this is an old age home. And there is, at the same time, practice has changed. Many patients aren't well connected to their GPs. Many GPs don't have hospital privileges or work in acute care hospitals. A lot of them follow their patients into res care, but in some cases may not even have privileges to work in that facility. I've seen that, believe it or not. And on the other hand, because they're not in tight, knit call groups where they're covering patients robustly, they often sign their call out to call services or call services where call is provided, say, by a resident or a physician who's in a completely another area and has no privileges in the facility that the patient is in. So it's not really surprising that when a patient gets into crisis, nobody's talked to them about these kinds of crises occurring. You call the doctor on call, they say go to the hospital. Not really surprising. Physicians are, like everybody, we need to move to teaching our physicians, teaching all of our public that palliative care is not something one dies of. You're not going to run into trouble if you have palliative care applied to you too early. It's not like if you start helping patients when I say palliative care, I don't mean fancy pain pumps and high-level specialist consult. I mean the simple idea that you recognize that the patient has an incurable illness, that you make plans about who's going to care, and that means that there's going to be an expected deterioration. If there's going to be an expected deterioration, what's going to happen when that happens? Who's going to come? Who's going to care for them? What do they want? So you have those conversations around what the real goals of care are. And then you put in place a robust system to care for them as that or when that happens. And whether it happens, 3 months after the conversation or 6 months after the conversation doesn't make a lot of difference to me, because you've made those preparation. You've made that preparation. And so, one of the things I often talk about when I talk to physicians especially is I start to make them think about what their level of responsibility would be if their patients were pregnant. If you're pregnant, if you have a patient, a young woman who's pregnant, there's going to be a baby in 9 months. If you have a patient who has a very, very advanced disease, say multiple admissions for exacerbations of COPD or CHF, or a very advanced dementia with most of their time spent lying down in bed, they're likely to be dead in a year. And in our case, a lot shorter than that. So we have to start thinking about what's going to happen. So doctors, that's one of the big problems. And, it's something we can do. And, Andrea said, if you can't measure it, it doesn't exist. But I actually think that the truth is, if you can't measure it, then you can't really change behavior. Because it's very easy to stand here and say, we should do better, and to stand in front of doctors and say, you really should do better. But if you can't feed back to them how they're doing badly or how they're doing better, it's very difficult to get them to change. The next group I'm going to pick on are the care providers, people working in res care. We all know the problems. You probably know it way better than I do. It really comes down to everybody thinking that somebody else is going to do this work. Everybody's uncomfortable with these conversations. Everybody is hoping that somebody else will do it. Sometimes the physicians will be upset if somebody like a care aide was to suggest to a family that maybe palliative care would be something they could benefit from. So there are lots of barriers between people inside of the care team. There's lots of barriers in terms of the way that we talk to each other around this stuff. So, for instance, this bottom one here about crushed medications. It came to my attention recently that a patient in res care who now may be unable to swallow their medications, mostly because they're dying, the nurse will phone up the doctor in his office and say, Mrs. Jones is not swallowing. We need to start. Is it okay if we crush the meds? And the doctor says, sure, no problem. Instead of somebody saying, wait a minute, why? Why is she not swallowing? And does she need these medications anymore? So it's that kind of lack of unity in the way that we talk about it. Staffing capacity, obviously, this is a huge issue, as you know. It's easy to say we need more nurses in res care. I think we don't recognize how sick these patients are and how much care they need. And we also don't recognize that at times and in different places inside our facilities, in different units and in different facilities, sometimes nurses can be faced with extremely sick patients. And sometimes everybody can be pretty stable. So, last night, for instance, I'll just tell you this, we had 4 deaths in our hospice of 10 beds. Everybody looked pretty okay yesterday, but things changed very fast. and we don't have much flexibility to change this, to change and to gear up to support them better. On the other hand, if you're trying to die at home, where we say people should die if they can, and we'd like to support them to do that, we have the ability to provide services, to provide shift care nursing in the last 72 hours of life, to provide equipment, etc. But we don't have this ability to respond in residential care. Of course, if nobody talks to families, they don't know what's going on. You know, they're not, unless they're, have a medical background, or they're extremely attentive and asking questions and getting answers on top of that, because that's another thing that doesn't happen. So families, it's not really surprising that they're going to maybe have unrealistic expectations about what's going to happen with their loved one or what's going on in this process. If they don't have information, they can't be expected to make choices about really beneficial treatments. So they're not saying, look, I want you to send mom to the emergency because I don't understand. They're saying, I want you to send mom to the emergency because I think that's going to help. We haven't done a good job, if that's not the case, of telling them that that's not the case. And so I think that there's a lot of stuff that goes on for these patients that somebody called it inappropriate treatment, but I actually think it's harmful. And I think that in many cases we can show that. If we don't collect that information, track that in some way and start feeding it back, nobody even notices it. These are the administrative, we call them administrative, I had another title before, but we call them administrative problems. There's all sorts of structural barriers that were put in place historically because these were old age homes, places where people went to live in the last years of their lives. And we haven't really managed to move a lot of this to start to expect and to acknowledge that these patients are going to die. We have things like where patients have to have monthly weights. Well, that's an interesting thing to talk about, because weight loss in a fairly stable elderly patient with a chronic incurable disease is quite a good sign, quite a good predictor of deterioration. So on the one hand, we should be weighing them. On the other hand, if we know that they're now into this dying phase and this dying trajectory, then dragging them through monthly weight loss and reporting it is counterproductive. There are no requirements to actually have care plans. I mean, when I'm not talking about advanced care planning, I'm talking about goals of care, real discussions. There's no actual requirements around that. Lots of our level of intervention forms are different in the different facilities. That's confusing to physicians who may be covering different facilities or covering physicians in other areas altogether. So those are those things. When you move into long-term care, nowadays you've usually spent quite a while waiting somewhere else. In my experience, and this is my little passion of the moment, we have patients sitting in our acute care beds waiting to go into res care. You have to be pretty sick, I can tell you. And once they go into that MDS thing, AAP, assessed and awaiting placement, nothing happens. Nothing happens. They may have been there for months. They may wait for months, but nobody takes that opportunity, although they have at that stage fairly stable medical physician coverage. They need to be rounded on daily because they're in acute care hospital, and they have fairly stable nursing coverage, and everybody's in this, and families are around usually because they're making these decisions. Nobody sits down and says, okay, let's talk about what's going to happen when you get there. They leave that conversation for when you move to res care. Pretty traumatic event, you can imagine. I'm sure you all know this. When you move into res care, that's a traumatic event. There's a lot of loss, a loss of independence, and a loss of previous parts of your life. There's a lot of different things to get used to. Res care tends to put off those conversations if they're not very carefully structured. Very easy for a patient to go into res care and 3 months later someone says, oh, well, maybe we should talk about what the plan is. Or the doctor signs the level of intervention without really explaining what this means to the family. Don't quote me on that. But really, not really in terms of, or without making sure that the family understands exactly what that means. So I think we have a big opportunity to deal with a lot of these things before patients go in. And this needs to be attached to our MDS process. Oops, sorry, wrong one. Got it. You know about this more than I do. I'm sure everybody knows what res care facilities look like. Pretty shabby in some cases, multiple bedrooms, lots of old equipment, some mattresses that I guarantee you none of you would sleep on, and also limited equipment as these patients get into that last phase, to get air mattresses or to get privacy for them, to get equipment that, by the way, we can put into patients' homes under the BC Palliative Benefits Program, and often, but we expect the res care facilities to provide this. And of course, their limited budgets, their limited funds, is very difficult. So it's not always the nicest place to die, for sure, but a lot of people still die there. Anybody else? Bella's going to tell you how to fix this.
So I'm going to feel a little bit like Pollyanna and tell you how we can, the strategies that we can use. And I think many of you already know a lot of the strategies and have already, are probably thinking in your mind, and as you see some of the things that we talk about, say, oh yeah, we do that. And I have to say it was fun working with the three of you to bring this together. And so these strategies that we're suggesting are just brainstorming between the four of us. So the barrier, and I think, Peter, you described very well, so I'm going to, in the interest of time, because we're getting short on time, I'll miss the physician section because you talked about that. But the basic philosophy, I really believe that if we can all agree that that we integrate a palliative approach, that it begins when a person first moves into residential care. That if we can all agree on that philosophy, that, I think, is a real basic premise to providing better care. And that we need to continue advanced care planning conversations the first week that the person and the family move in. I'm using the word continue a little carefully because that's the assumption that advanced care planning conversations have already begun, hopefully years before the person's even moved in. By the time they move into residential care, advanced care planning is kind of a misnomer, isn't it? And some people will say to me, staff will say to me, but Gina, I can't have those conversations in the first week because I don't know them well enough. And what families have told us in focus groups is they don't need to be our best buddy to have these conversations. They want to talk about them, and they want us to initiate the conversation. And so I put up a few sort of open liners just to give you a flair for what we're talking about when we're talking about these conversations. It could be something as simple as, and of course we would change the wording a little bit if we were talking to the family instead of the resident, but it could be as simple as, if you couldn't speak for yourself, who do you know the best that would be able to make decisions for you? And what we're doing now in many cases is asking, who's your next of kin? Legally, that's not an appropriate question, and it also doesn't tell us who knows them best to be able to direct their care. Another question would be, have you ever written anything down? There's a good chance that many of our folks have had a relationship with a family physician for the past 10 or 20 years, and that something's written down in the GP office. And yet, have we ever connected with the GP to see if there's something written down? Or if we ask, what's important to you? Not, what do you want? And how many times do we go to a family member and say, your mom's short of breath, what do you want us to do? That's not the question, because the question is, what's important to your mom? And based on what's important to your mom, we will decide what we should do. That's a huge burden to ask families, what do you want us to do? What is your understanding of why you're living here? So if a nurse asks that when they first move in and find out, as many times I have, that the son actually thinks that mom is living here because she's eccentric and old, then I know I need to talk to the physician to say, you know what, they need to know about diagnosis and prognosis. So that the physician can sit down with the son and the resident and say, you know, your mom has Alzheimer's disease. And that's a progressive disease, and it's brain failure. And so we know as the brain continues to fail that your mom is going to start to lose the ability to walk. She's going to start to lose the ability to talk, to use the bathroom properly, to eat, to swallow, to use the food. She's going to lose the ability to fight off infections. And her immune system is going to lose the ability even to use antibiotics, so that antibiotics aren't going to work either. And that's the normal progression of brain failure, which is what your mom has. So treatments like sending her to hospital at the end of her life for antibiotics or for tube feeding, those are burdensome because they're actually not going to promote comfort. Wouldn't that be amazing if every family member had an opportunity to get that kind of information when they first moved in? Another question I think would be great to know is, what are your goals for living here? And more importantly, what are your fears? Think of the myths that we could bust by knowing fears. And then, of course, there's our care providers. And for those of you who don't know what I mean by embedding the surprise question, it's a question that nurses are very good at, actually. And that is, would you be surprised if Mrs. Smith died in the next 6 months? Nurses are actually pretty good at thinking about how frail they are with all their comorbidities and predicting whether they would be surprised or not. And so having that skill, should we not be doing that on a regular basis? Asking, whether it's at care conferences, shouldn't the physicians and the pharmacists during medication reviews every 6 months know that, you know what, we wouldn't be surprised if they weren't here in 6 months? Wouldn't that make a difference to the medications that they would be continuing to prescribe? Or during our MDS reviews, we should be having weekly rounds and saying, I wouldn't be surprised if Mrs. Smith died in the next 6 months. And then the next question is, does the family know that? Because the family deserve to know that. And what families have told me is, you know what, they're okay if we're wrong because they know we don't have a crystal ball, but they'd rather know that and make plans because maybe they won't go to Mexico at Christmas time and us be wrong than not to know and miss the opportunity. So whenever there's a change in our resident, let's stop and think, could this change be the result of dying? Families. In so many cases, I think families come into moving into residential care and they have unrealistic expectations. So could we be giving them written materials before they move in so that they have the information so they don't have unrealistic expectations? Every residential care home has a family council. How can we encourage families to attend family council so they can learn more about advanced care planning and the dementia trajectory? And we need to stop asking families, what do you want us to do, and start asking them, what's important to your loved one? In administration, Peter's already talked about how many different forms there are. And until Fraser Health went to MOST, which is Medical Order for Scope of Treatment, there were 83 facilities with 83 different forms. And also each hospital had their different forms, DNR forms, and the community had their own form. So now we have one form. So everybody's understanding what the person's wishes are. We need to be able to somehow influence the performance indicators that every care home has to send to the Ministry of Health. Because right now, we are judged by whether people lose weight or not. If we're looking after people at the end of their life, do you know anyone at the end of their life that doesn't lose weight? And people who getting skin, having their skin integrity impaired is a normal part of what happens at the end of someone's life. So why is the Ministry of Health judging our good care based on that rather than indicators that might be better indicators of quality care? Our care plans need to reflect the goals of care of that individual. And we need to develop a competency. We need to develop an expectation of competency in all our staff. Whether it's when we're hiring people or when we're doing performance reviews, we need to expect that staff have a level of competency in developing a palliative approach. And lastly, the system or the policy. I don't know what the model is. All of us work in different areas and we all have work from different models. But we need to have a model in residential care that builds capacity. So rather than relying on one or two people parachuting in and rescuing people who are palliative, we need to develop a model where every single person working in residential care has the capacity to provide a palliative approach. Andrea, who spoke at the last session on anti-psychotics, is creating in Vancouver Coastal a pathway that will embed the palliative approach. So there'll be moments or triggers or red flags for staff. That might be an excellent opportunity. I know in the UK they also have a pathway. And we need to be using an actively dying protocol so that, and we know from research that care homes that use an actively dying protocol, then when a person has symptoms at the end of their life, they can be managed, whether it's 11 o'clock at night or a long weekend. The medications are there and the orders are there so that they can manage the symptoms rather than the person having to go to the hospital. So residential care is in the business of quality living, but it's also in the business of quality dying. And so integrating a palliative approach in residential care does make a difference.
Thank you very much. We do have time for questions, so if anyone has any questions, please step up to the mic. Hi.
I represent several seniors and retirees in the Fraser Valley because I'm associated with several senior groups, and I serve on the executive of these groups, and several of them know that I'm attending this conference on residential care facilities, and I can guarantee you that by the end of next week, every one of them will know that I attended this. Now, the question I'm putting to you is, how do I tell these people when they ask me about choosing a residential care facility for their loved ones? Are they gauged, or just what information can I give them that will enhance their decision-making process? Thank you.
I think there's also people in the audience who could answer this, but we're required to put sort of information in a standardized form on the internet so that people could, if they had access or their family had access to the internet, there is information on each facility on the health authority's website. So that is a starting point. There are also people that they could connect with in the health authority to get more information about facilities. So there are public sources of information that they can access, and I think that's where I would start to look if I didn't know anyone. There's also networking with people who have had the experience as well. But it is a complex system, and it is sometimes very difficult for people to navigate. Is there anyone in the audience? I know Sue's here. Did you want to answer, Sue, or?
Just while Sue's getting up, I just wanted to add, I've already let my husband know that I need to have a garden. So whatever care home that he chooses to put me in, I need to access to the outdoors to go out and get dirt under my fingernails. So even just looking at the physical layout might be how you decide which care home is your favorite.
Yeah. There's a number of places you might find information about specific care facilities. So under your health authority residential care program, there's often a good description of residential care facilities. Under the assisted living registrars, there are some descriptions of assisted living residences. And then if you're interested in inspection reports, and that's just summary inspection reports on residential care facilities, they're under the community care licensing program of your health authority. They're not as descriptive, I would say, as if you look on the residential care services website, they'll have more of a description of the services offered.
I don't really have a question, but I just want to thank the panel very much on behalf of those of us who do provide care for this open and honest approach. It's been desperately needed for some time, and it's so helpful for our residents if we can go in right from the beginning that we used to look at the only time you were palliative as if you had cancer, and the reality is aging is a part of that. So I just thank you so much for your work in this area.
Thank you for this opportunity. My name is Lynn England. I'm currently chair of the Vancouver Island Association of Family Councils, the only regional association of family councils within the province of British Columbia. Hearing that every facility has a family council, I would like to know that that was fact. In fact, all residential care facilities have the opportunity to have working family councils. Unfortunately, not all of them have family councils. I'm also chair of the Advocates for Care Reform, wonderful website, good resource material for anyone who so desires to start a family council, and there are contact numbers listed there. Family councils are important. They do great work, and I would encourage anyone here to look at the website, contact someone there for any information. If there are people in the room that are interested in starting a family council in their facility and want more information about the Vancouver Island Association of Family Councils, we're currently setting up a website. Thank you.
I'd like to ask you a question. Has your family council ever hosted any information on dementia, the progression of dementia to death, and things like that?
Yes, at our AGM, we always have speakers that are very informative, and actually last year that was one of the focus points. Yes. Thank you.
Can I ask from here question? I'm member of the Seniors Advisory Committee appointed by City Council of Vancouver. Sorry. Didn't want to make it good, but I have. My name is Eva Wadolna. I am member of the Vancouver Seniors Advisory Committee, and I'm going to write a blog for our webpage about this particular session. My question is, how can we ask people, what should we ask people to do to assure good death and dying? What would be the one sine qua non condition for that?
I would say, just to start off, that probably the first thing is to talk with your family about dying and things of what is important to you. Because as a place to start, if people are talking within their families about what is important to them, then if the person or when the person's no longer able to speak for themselves, the families actually know what it is that is important to their spouse or their father, to be able to advocate for them, rather than feeling the burden of trying to think, and often what gets mixed up is think, what would I want for my dad, versus what did dad tell me was important to him. So I think that's a place to start for people, is talking with their family members so that they can be their advocate for their voice. I'm curious what others.
I totally agree, and I think if it's difficult to actually use the D word, many people will remember conversations that their loved ones had when they saw other people in those situations of multiple illnesses and so on. I've often had people say, oh, we never talked about it, but then asking them tell me about your mother was very important, because it often brought back clear clues that mom and dad had given, because not everybody feels comfortable with the full-on approach. But you can say, Mom, I've noticed that you seem to really, hate going to the hospital, or do you mind going to the hospital? Even simple questions like that.
My question is a little bit different, because I'm asking what is the legal obligation of the healthcare providers to actually adhere to the wishes of the family.
Oh, beg your pardon. Okay. We probably could both give that a go.
Okay. That's what I wanted to hear.
The obligation of the healthcare provider is to the person. So if I know what Romaine's wishes are as a healthcare provider, I'm obligated to try and respect those wishes, even though Romaine's husband maybe has a different idea. But if Romaine has expressed those wishes, they've been clearly documented, then as healthcare providers, we have an obligation to direct our care based on what Romaine's wishes has been. Is that your question?
And what would be clearly documented? What would be the meaning of it?
So, does anybody else want to?
Well, I think the difficulty is if you're asking, could we be legally liable if we don't follow the directions in someone's advance directive? Is that really what you're asking?
Yeah.
We are not, we are obligated to follow the directions, providing that makes healthcare sense. So if someone said, I want to be resuscitated, even though I am clearly dying, we are not obligated to do that. We are not obligated to offer treatments which, in the opinion of the healthcare team, are not beneficial to the patient. So you can't, most of the time people are writing directives to say, I don't want to be resuscitated, or I don't want this or that. But in the case of people requesting treatments that are not medically appropriate or are highly unlikely to benefit them in any way, we are not obligated to provide those, to offer those.
But the things have to be in written form, right, to make it easier on the staff?
Things are... You mean
advanced directives have to be...
No. What's important is the conversation and the transmission of that conversation. It's great if it's written down, because that can be helpful. But it's not an actual requirement in order for something to happen.
Okay, thank you. I think it needs additional conversation, but thank you very much.
Yeah, it's complicated. I agree with you.
I just wanted to bring everyone's attention to the PATH Clinic in Halifax. PATH, it stands for Palliative and Therapeutic Harmonization. And it's an extraordinary clinic for frail elders where they do extensive assessment, prognosis, and very detailed counseling with the family and the frail elder about what the results of various treatments, medications, interventions could be in light of their frailty. There's some wonderful resources on that website and also a video explaining their philosophy. They came out and did some training here, and I also arranged for them to do a public forum. So I really highly recommend you just Google PATH Clinic. It's probably pathclinic.ca, but I'm not absolutely sure. I highly recommend having a look.
So I want to thank the audience for your attention and very much thank the panel for the information that they shared with us.
Okay, it's my responsibility to wrap up proceedings. I don't want to take up too much of your time. It's been an absolutely huge pleasure to hear all the talks over the last couple of days and to meet as many of the attendees as possible. And I actually don't think I can add anything more to the tremendous presentations and discussions over the last couple of days. So I'd like you to show your appreciation to all the speakers who've made such great presentations. I'd like to stress the value placed by SFU and the Gerontology Research Center on the whole issue of knowledge sharing and knowledge mobilization. These conferences, I think, are really important for universities such as SFU and for our research center to engage with the community partners. And I hope the conferences provided insights, ideas, and models of good practice that can be applied to improving the care and well-being of those people of BC who live in residential care. From a provider and practice perspective, this is not an easy task. The topics we have covered are very challenging. And indeed, they've been issues for a long time. And we still have difficulties in dealing with them. And perhaps this is the reason why we see them as taboo topics. A key aspect here is communication, education, and training of staff who work in residential care. And we hope those people who've attended over the last couple of days can share their experience with other colleagues and staff. And to follow that up, there's going to be a video of the whole conference and last night's public lecture available on the Gerontology Research Center website, together with the PowerPoints. So those are going to be made available in probably take about 4 weeks to get everything edited and up on the website. So I really encourage you to keep checking and have a look for that. Just some thank yous to finish everything off. I'd like to thank our partners, which are Fraser Health, the BC Ministry of Health Seniors Directorate, the Public Guardian and Trustee of British Columbia, and Vancouver Coastal Health. On the organizing committee, there are too many people to mention, so I would recommend you to have a look at the conference program. But I would like to make special mention to Shannon Berg, who's the Executive Director of Home and Community Care, Vancouver Coastal Health. Sherry Harriman, Director of Clinical Programs, Abbotsford, Chilliwack, Residential Care, Assisted Living and Specialized Populations. Alison Leaney, Provincial Coordinator for Vulnerable Adults Community Response, Office of the Public Guardian and Trustee of British Columbia, and Christine Massey, who is our Executive Director of the Seniors Directorate, BC Ministry of Health. And then finally, the conference team, for whom we owe a lot, especially Gloria Gutman, who has been the indefatigable program chair and conference manager. Thank you, Gloria. And Gloria's team, which includes Melinda Aiken, volunteers, Sarah Wu, Laura Bowie, and Ryan Woolrich, together with Rosalind McEwen and Anne-Marie Barrett. So thank you to everybody who's contributed to the conference, and especially a thank you to everybody who's attended the conference and made this such a great success. Thank you very much.